Hello, good morning, good evening, good afternoon, depending on where in the world you're watching this and at what time. I'm Robert Scott Lang. I go by Scott. I'm a pediatric anesthesiologist at Nemours Children's Health in Delaware in the United States. I'm going to talk about a paper that we published called Spinal versus General Anesthesia, comparing outcomes in pediatric patients undergoing urologic procedures. Before I get started, I do want to say I have no financial disclosures. I don't own any stock. I don't make any money off of this. In fact, my pockets are relatively empty. So if you guys do have a good way I can make some money off this, let me know. I'd be all ears. I thought I would talk a little bit about myself so that you guys can get an idea of where I'm coming from and my interests, why I'm so interested in this, and how I have a little bit of expertise in talking about it as well. My medical career started in Philadelphia, Pennsylvania at the Temple University, the Lewis Katz School of Medicine. And I was very fortunate enough to get a residency in anesthesiology and then follow up that with fellowship training in pediatric anesthesia and in regional anesthesia and acute pain medicine. This was all at UPMC, or the University of Pittsburgh Medical Center. It is a huge hospital system with a lot of anesthesiologists coming from all walks of life. I got to see a lot of different techniques, a lot of wonderful ways of treating the same thing in different manners, and it allowed me to take what I thought was an amazing way of doing it and keep it, and then what I thought was kind of not very good, and go ahead and throw that away. And I use that going forward as an attending anesthesiologist. I stayed on staff at their children's hospital for about 3 to 4 years or so as one of their acute pain physicians doing nerve blocks for perisurgical patients and then perisurgical pain management. I later was then hired away by Nemours Children's Health in Delaware. At the time, it was Alfred I. DuPont Hospital for Children. We have since rebranded to Nemours with that really cool forever green and that interesting symbol that we have there. I later became their medical director of their pain service. This is a perisurgical acute pain service. We do dabble in longer term pain control with our chronic pain physicians and our palliative care team. They will assist us in those patients. I'm also the director of transplant anesthesia. And in addition to optimizing outcomes with those procedures, I work on optimizing pain control, not only for our recipient pediatric patients, but also their donor adult family members who give their organs. Um, I'm also the co-chair of the Opioid Stewardship Committee for the entire enterprise. Nemours has a hospital in Delaware, but they also have hospitals in Florida as well. So it's an enterprise-wide effort to make sure that we maximize our stewardship. And that is what I'm interested in, minimizing and eliminating opioids when it's appropriate. I do understand that opioids may not always be eliminated. They are appropriate in certain circumstances, but I really like to mitigate the side effects of these medications and mitigate the long-term sequelae, such as substance use disorder, improper disposal, and things like that. I also want to maximize regional anesthesia to improve patient outcomes and patient satisfaction. A good example of this is we instituted a robust regional anesthetic program for osteogenesis imperfecta patients. And after rounding on them, after they've had their intramedullary rotting of their legs or their arms, with a nerve block, they will say that it's usually the best post-op experience they've had in a very long time or ever. And it's very important for us to limit the amount of opioids they take that would cause constipation, nausea, vomiting, loopiness, and things like that. So for the rest of this talk, we'll talk a little bit about general anesthesia and spinal anesthetic. It's a very brief pro-con presentation of these two. It's a huge subject, so it's going to be very brief and very limited. I'll talk about the paper itself, go through methods, go through the conclusions. And after I hear about a paper or read a paper or listen to a presentation, poster, abstract, I always wonder, that was historical data. What's going on now? And what are you going to do with it going in the future? So I'll just very briefly touch on that for what we're doing with spinal anesthetics now. So let's talk about spinal versus general anesthesia. We'll go over the pros, we'll go over the cons. So that's a sevoflurane bottle up north. That is inhalational agent that will allow us to induce general anesthesia. And off to the side, right next to me, is a Quinky needle, which is the needle that we use for our spinal anesthetics. So what are the pros of general anesthetics? Well, we're comfortable with it. We're a 100% pediatric hospital. We're very familiar with putting children off to sleep. And not only are the anesthesiologists, anesthetists, nurse anesthetists familiar with general anesthesia, but so are our surgeons. So they know what to expect with general anesthesia. They know their children will be asleep. They know their children will not move during surgery. And with all this experience breeds expertise. We tend to do it a lot. We do it all day, every day. So we're very good at it and very familiar with it. And usually it's technically easier. Bring the child in, inhalation induce, start the IV, and place an airway if you need it. Can be very straightforward for us. And there's an asterisk there because anesthesia can be easy until it's not. And then I'll talk about that in the cons coming up. And while the children are asleep, you can very easily supplement with a regional anesthetic. You can place a caudal block where the child is asleep and they don't feel the needle and they don't move while you're trying to place it. It's very easy and straightforward for us. But going along with that asterisk, but technically easier, you may see airway complications. You might have a patient with difficult airway. If you have a Morchio patient, mucopolysaccharidosis type 4, they could have extremely difficult airways. You might have a retrognathic patient. You might have a patient with macroglossia. You might see bronchospasm, laryngospasm. You might see desaturations with bradycardia or worse. In addition to this, you might see hemodynamic instability while under general anesthesia for our kids. They might have very low blood pressures, which you might need to supplement with either fluid or with vasoactive medications. Neurotoxicity is a concern. There's a star there, an asterisk there, because it is. There's a lot of data, especially over the last several years, on neurotoxicity. Do these general anesthetics cause long-term behavioral or cognitive issues? Is it how we run our anesthetics, or is it the anesthetics itself? Is it a combination of both? Neurotoxicity has received a lot of attention recently, to the point where the United States FDA has issued a warning for these, which patients' parents will see and will ask questions about. So anytime that you might be able to avoid the potential neurotoxicity, it might be better off for the child. And then there are the environmental factors. Again, this has an asterisk because sevoflurane is a greenhouse gas, and so is nitrous oxide. In fact, nitrous oxide could last about 120 years in the atmosphere. It's more potent than methane or carbon dioxide. So there's a big environmental influence that these general anesthetics have. But there's also a carbon footprint associated with washing and sterilizing reusable equipment that could be associated with regional anesthetics. So it's not a complete environmental factor detriment for general anesthetics. It's for almost everything we do in the operating room. In fact, oxygen has a carbon footprint when we use it and the way we use it, and that includes oxygen used for spinal anesthetics. So let's talk about spinal anesthetics. What are the pros? Well, you can avoid most of the cons that you see above. Avoid airway manipulation, avoid hemodynamic instability. When you do a spinal in an infant or a neonate, you do not see the sympathectomy that you would see with the adults. So you don't see that low blood pressure you might see in that parturient, the adult mother giving birth. And it's a very old technique. It's been around for a while, and it's even established in other pediatric procedures. And the hope is with spinal anesthetics, you can reduce your PACU and your OR times. But it is more technically challenging, especially in infants and neonates. The space is very small, and these patients are awake when we do them. So you have to position them while they're awake. And that's usually, in the experience that I've had with the many spinal anesthetics I've done, the positioning is the least well tolerated portion because the children do not like being sort of bent into the position to open up the space. And being awake also means there's an age limit. If you are to hold a patient into position, it gets harder the older they are. And a lot of times you still can't reason with a 2 or 3-year-old to stay still for spinal placement, but they're going to be a lot stronger. So there is an age limit that you can do this. If there are any spinal abnormalities, you might want to avoid a spinal anesthetic. And then it's a new concept for patients to think about spinals for their children. They've a lot of times have heard of spinal anesthetics or even had it themselves. But when it comes to their infant, it's a new concept to them. So it may be hard to get the consent for it. So let's talk about the paper now. We'll go through the methods, the statistical analysis, the results, and then we'll talk about the conclusion. And this paper was published because we're always seeking ways to improve our outcomes and our patient experiences. At the time of publication, there was a relative paucity of data for spinal anesthetics in children undergoing urologic procedures. So our hypothesis for the paper was that spinal anesthesia, as compared to general anesthesia, would have fewer intraoperative and postoperative complications. It would have shorter operative times and potentially decrease our overall costs to family and hospital. The overarching theme is, of course, spinal anesthesia better be as good as general anesthesia, or else we're not going to do it. So what we did was a retrospective study of prospectively collected data. The time frame of this was from May 2019 to July 2021, and we used our electronic medical record to collect the data. And we used certain programs like ClickSense to help extract certain points of data that we needed for analysis. The children either got spinal anesthetics or general anesthetics. There are about 386 children in all in this study. About 202 were general anesthetics and about 184 were spinal anesthetics. And these children were all 18 months or less in age, as that was the age that we found that we're more easily able to place the spinal in more safely. These, of course, were all urologic procedures, so hernia repair, orchiopexy, circumcision, and resection of urethral valves. And of course, if you look at the dates of there, and we got our little friend there during that time, COVID did happen during that time, so the total number of patients is probably significantly less than what we were expecting at the time. But you make do with what you got. Before I go into the statistical analysis, I do want to go into how we did this perioperative management of these patients. In the pre-op holding, we'd have a discussion with the patient's parents and get consent for the spinal anesthetic. If we were lucky, and oftentimes we were, the urologist in their pre-op clinic would introduce the topic of spinal, so it wasn't a new thing for them to consider on the day of surgery. Once we got consent for the spinal, or if we didn't, we would go for general anesthesia. But once the consent was obtained, we would prep the patient with 2 mics per kilo of Precedex intranasally, giving about 45 minutes. That will give the child enough time to fall asleep with it. And then we also place numbing cream on the back in the area where we're going to place our spinal anesthetic. And this usually takes about 30 to 45 minutes to kick in as well. So when we're ready to get into the operating room, we bring in our sleeping baby, we place our monitors, and we position the patient for the spinal. This usually wakes up the little child while we're working, because you need to push the head down a little bit and arch the back a little bit. And no child really necessarily wants to be in that position if they don't do it themselves. So we either position sitting up or in one of the lateral decubitus positions. And at that time, we will place our spinal needle. And then during the procedure, we'll make sure that the spinal is set and they're not feeling anything in their legs, so we can place the peripheral venous catheter and our blood pressure cuff and pulse ox. The blood pressure cuff on the lower extremity, because when it goes off, we don't want it to go off on the arm and wake up the child. Generally, with a Precedex, the children will sleep through the procedure. If not, we can supplement with a little white noise off our phones or little lullabies. Creates a nice relaxing environment for the child and also for the urologist. They tend to calm down a little bit too. Postoperatively, we evaluate the patients, provide the parents with their instructions, and then send them home. So let's talk about our statistical analysis. We looked at our times, induction of anesthesia time, emergence time, total anesthetic time, as well as PACU and surgical time in general. We also looked at pain control and our opioid use, and then the relative costs of each general anesthetic and spinal anesthetics. So for the data, to account for the differences in total or special surgical time, to help categorize it into quintiles, we introduced a variable that'll help account for the surgical differences, surgery type, surgical skill, and surgery location. We use propensity score matching to decrease the variability between the two groups. And we use multiple logistic regression for matching. And for unmatched patients, we compared them using either a chi-square test or a two-sample t-test. And for the categorical variables, we use the Nemours or marginal homogeneity tests. And for cost analysis, we used univariable or multivariable linear regression. Okay, so I said all that and almost sounded like I knew what I was talking about, but I do want to say that I'm no statistician, so please don't ask me too many more questions about this. I left this to much smarter people than I. So, what were our results? Well, when we looked at our perisurgical times, interestingly, our induction of anesthesia for spinal anesthesia was longer. But when you incorporate that into total anesthesia time and emergence time, total anesthesia and emergence time were less. In the PACU and the OR, the surgical time and the PACU times were all about the same. And I have some caveats to that I'll talk about in a second. In terms of complications, there were no complications in the spinal anesthesia group. There were 6 complications in the general anesthesia group, including desaturations, which would require epinephrine or bronchodilators, replacement of the airway, hemodynamic compromise, and even a PICU admission. Only the general anesthetic patients got opioids. None of the patients in spinal anesthesia group got an opioid, which is a huge success for that group. And then in terms of cost, it ended up being no significant difference. It was pretty much a wash with the cost. So I'd referenced this in the Times. These are some considerations that we discussed as we published this paper. The induction time was longer for spinal anesthesia, but that's also because we were learning on the job. I had done spinal anesthetics in adults before this, but very few in children. So even I was learning how to do a spinal anesthetic while we're recording our data. So now that we've all gotten very good at it and much more efficient, I bet you if we were to look at this time again now, it would be significantly less. Same thing with the PACU time. At the time, we were waiting for the patients to move their legs, waiting for the full spinal to wear off. And if it was a very quick procedure, it would take a while in the PACU for the spinal to wear off. We now have since mirrored certain other institutions in the United States. We're not necessarily waiting for leg movement, but we are providing ways that the patient's parents can contact us post-op if they have any concerns. So in conclusion, spinal anesthetics are equally effective as general anesthetics. And when you look at total anesthetic time, opioid use, serious complications, and postoperative rescue medications, they were all less in the spinal anesthesia group, which is a big win for the spinal anesthesia group. But when you looked at cost, that was a wash. It was all about the same. I believe the numbers were 8,100 to 8,200, looking at the two different groups. So we published this paper, and we found that we really enjoyed using spinal anesthetics. The parents were happy, the anesthesiologists were happy, and the urologists were happy. So are we still doing it now, and are we going to continue to use in the future? Yes, we've done well over 650 spinal anesthetics, probably closer to 700 by the time I'm recording this. And we have opened it up to all surgical procedures amenable to spinals. That includes general surgeons and the occasional orthopedic procedure. We've opened up the opportunity for trainees to learn how to do spinal anesthetics in infants. This is usually fellowship trainees and things of that nature. And we really hope to generate more data going in the future to further the efforts. We found that spinal anesthetics tend to have done a really good job for our patients. We're very happy with our outcomes. So, do you guys have any questions for me? I appreciate it if you have any questions. Try not to ask too many questions on SATS, though.